Okay, so welcome to Take Charge for September of 2018. So tonight we're in for a treat. Unfortunately, we're all familiar with cancer to some degree or another. You're at least familiar with what cancer is, and unfortunately, a number of you, I'm sure, have firsthand experience of having cancer, not for yourself, probably somebody very near and dear to you. The great news is our population's getting older, which is good, but as we're getting older, we're starting to see more and more cancer, and cancer is currently the leading cause of death in the developed world. So tonight we're going to hear a little bit about cancer, where it's gone through the decades, how our thinking about cancer has changed and evolved, a little bit about how our treatment and management has evolved over the decades as well. We're going to be led by Dr. Harvey Schipper. Dr. Schipper is an oncologist working out of St. Mike's Hospital. He's also a professor with the University of Toronto, and we're very fortunate in that he's our medical support for the breast cancer program that we run here on Friday mornings. So he's going to lead us through this discussion. Dr. Schipper, you guys are going to enjoy this. It's great. Come on down. All you?
Thank you.
You're welcome.
What I hope to do, and typically when I meet with people on Friday afternoons, we'll start with a topic and we'll end up off topic because people want to ask questions, and that's just fine. But here's where I want to go. I want to give you a very broad sense using cancer as the kind of example about where medicine is going, how it's changing, and at the end maybe you'll have a few ideas about how you read the newspapers, how you talk to your doctor, how you think about all this stuff. Because it's changing very rapidly, it leaves people confused, and the reality is we're at the cusp of probably the most enormous change in our thinking about medicine and biology that we've had in the past 200 years. So I'm going to start with a story. And it's a true story, and it involves me a lot of years ago when I was a medical resident at the Mount Sinai Hospital when it was in the old Mount Sinai Hospital, which is now Toronto Rehab's building on University Avenue. And one late evening, my pager goes off. I'm the medical resident, and I'm called down to the emergency. And when I get to the emergency, lying on the gurney is a very elegant woman. She's about 80. And her eyes are clouding over. And it is clear she is really sick. And she's having a very big heart attack. And it's pretty clear that there's not much we can do. This is a long time ago. And so I walk up and I try to comfort her, and we start the IV and we're giving her some morphine. And she looks at me and says, "What's your name?" And I said, "Dr. Schipper." And she says, her eyes clouding over, "Dr. Schipper, are you married?" And I said, "No." And she said, "Have I got a girl for you?" And she died. And I've never figured out who that girl was, but I've been married for about 44 years, so I guess it's okay. That was then. What would happen now? Well, I might have that little conversation with her, am I married or not, if I were a resident. But in fact, within minutes, we would have diagnosed that she's having a heart attack. And within a few more minutes, she'd be up in the coronary catheter suite, and I wonder how many hands would go up if I said, "Have you been in there?" And they'd put in a stent, and off you'd go. That's an enormous change. And it reflects the first piece of what's changing so powerfully in medicine all over, and that's the emergence of modern medical technologies that change so quickly we can't keep up with them. When I work with the ministry from time to time talking about purchasing new equipment, it used to be that the time frame for purchasing a gadget, its lifespan, would be in decades, 10 years, maybe 20. Now it's 3 to 4 to 5 years. So the technologies are changing that rapidly. That's the first thing. The second thing is, had that been a lesser heart attack, patient would have received some morphine, some of the drugs that we still use, maybe some digitalis, maybe a diuretic, maybe something like that, and you'd be put to bed for, say, 6 weeks or 8 weeks and told, please don't move. Because if you move, you're going to hurt your heart. Now, we put in the stent, get you up, you just about walk back to your room, and you're referred into this program within days. The bodies haven't changed. It's the same kind of people who are having the heart attacks. But what's happened is our understanding, our conceptions of how the body works, how biology works, is profoundly changing. So we start with the technology, and now we look at the change in biology. And it used to be that the heart had to be put to rest. It had to heal. It had to scar over. And people were left with damaged hearts and a lot of fear that if they went up instead of 1 step at a time, they took the stairs 2 steps at a time, they'd have troubles. And now we know, based on a lot of evidence and clinical trials and things, which we weren't doing much back then, that programs that get you up and get you going lead to a healthier heart, to less cardiac damage, and to a much more normal lifespan, and more important, an important change in our quality of life. So the first thing is the technology changed. The second thing, our appreciation of the dynamic nature of the body has changed. And that goes to the biggest change in many ways. I'm going to use cancer as an example, because though I'm an oncologist, I once started as an engineer, and then I was an internist, and I never grew up, and I became an oncologist. If you go back 1,000 years, the concept with medicine was about spirits and humors in one way or another. Black bile, green bile, imbalances in these things. That's what characterized medicine, or the invasion of the body by spirits of one sort or another. And various cultures around the world had that. Starting in the 1700s, people started to observe differently, and we had some tools. The first thing we had is the scalpel, which allowed some very, very brave people like Michelangelo to actually sneak into the back room and start to do dissections. And from doing those dissections, you started to see what organs looked like. Oh, that's a kidney. That's a spleen. That's a liver. That's an eye. That's a brain. From the scalpel, a little bit later, came the microscope. And you started to look in greater detail, and you saw what the cells of a kidney looked like, what its organization looked like. You saw what a heart looked like. And suddenly we were really in the realm of anatomic medicine. Medicine defined by what you could see anatomically. This is what a kidney looked like. This is what a heart looked like. And to step into cancer now, you'd start to see lumps, and you'd see, geez, there's a lump in a kidney. And when we looked with the microscope, the early microscope, what you saw were cells that looked sort of like the kidney, but they were disorganized. So our notion of illness was based on organs. Though we were assembled of a whole bunch of organs, they were in many respects almost separate entities. The notion of their interaction was kind of lost. So that's why we've got kidney cancer, lung cancer, colon cancer, the list goes on. And drawing out of the days of anatomy, as we started to understand and observe anatomically how cancers grew and spread, we said, you know what? A cancer that starts in the colon, even if we find it for the first time in the liver, is a colon cancer. It's a cancer that may have spread from the colon to the liver. How does it look that way? How do we know that? Because it looks a little like a colon cancer, but the worse it is, the more disorganized it is. Sometimes it's very hard to tell. And sometimes we use the word anaplastic. We can't quite figure out what it is. But the whole notion was anatomic. Well, if the notion is anatomic, then what we got to do is fix what's anatomically wrong. Right? So, starting, would you believe, in Mesopotamian times, the way to treat a breast cancer was to take off the breast. The anesthetics weren't quite so good. But the first recorded mastectomy was from the times of Hammurabi, way back when. And if any of you happen to see the brilliant movie, TV series John Adams, with Paul Giamatti as President Adams, there's a very dramatic scene where his daughter gets breast cancer, and on camera you kind of see the removal of her breast. So we're going to shift a little more to breast cancer, and then we'll come back to other diseases and see how the change in thinking has percolated across all disciplines of medicine. But when we were dealing with anatomic medicine, we said, well, we've got this lump. And this lump has to be gotten rid of. And the only way we're going to get rid of this lump is by taking it out surgically. Because it's a race. These cells have transformed, and they're not following any instructions, and it's them or us. It's a race between the body and these cancer cells that seem to follow no instructions. So as our technologies got better, our surgical approaches got bigger. And that's the way we manage cancer, starting from Hammurabi through the growth of anesthetics in the 1850s, all the way into the 1960s and 70s. The notion was you have a process that's completely out of control, and it's kill or cure, and the notion was we've got to kill the last cancer cell, we've got to get the last cancer cell out of here. For me, the moment that got my thinking going a little bit differently was way back when I was a resident, and we were seeing somebody who had a particular kind of tumor that arises in muscle called a sarcoma, and it started in the leg, and we knew the natural history of these sarcomas is that they might start in the leg, but they tended to proceed to the lung. And I was asked to research the literature about what to do for this kind of sarcoma, for this kind of patient, and I came across a paper from the Sloan Kettering Hospital in New York, which is the major American East Coast cancer hospital then and now. It's a little bit in the news these days, a little bit of trouble at Sloan Kettering, but be that as it may. What was the approach to this? The approach was a hemicorporectomy. We're going to remove this part of the body from the belly button down, because that's the only way we can encompass this whole tumor. We got to eradicate or kill the last tumor cell. That was the model. It's the model that was applied to lung cancer, colon cancer, all the cancers you knew. And starting in the 1940s and 50s, people came up with drugs that seemed to kill cells, and that seemed to kill cancer cells a little bit better, if you will, than it killed normal cells. And that was the basis of chemotherapy. And chemotherapy had its first breakthroughs in treating leukemia in children. And of course you know that when I started training, children who got leukemia, 95% of them were dead within 6 months. Now the problem, in a way, is how do you make sure that the long-term, sometimes not so serious consequences of treatment don't get in the way of the 95% of kids with childhood leukemia who are now cured and go on to having normal lives. But it was in that setting that we saw drugs that appeared to kill cancer cells. And so, starting from childhood leukemia to Hodgkin's disease and stretching across a whole bunch of other diseases, we started to add other kinds of killing therapies. Surgery, chemotherapy, and radiation treatment. The idea being to give a dose of radiation that would kill the cancer cells because normal cells could recover a little bit better. And we made considerable advances. But there were always some people who tended to look at this and say, well, wait a minute. The answer isn't complete. And here I'm going to dive into breast cancer a little bit more. If you go as late as about 1974, if someone developed a breast cancer, the idea was to do the most extensive surgery that the technology could allow. And so we came up with something called the extended radical mastectomy. And that was to remove the breast, all the muscles on the chest wall, what we call the pectoralis muscles, all the lymph nodes under the arm. Then we split the sternum and took out the lymph nodes that were inside. Why? Because the belief was that this was an out-of-control process, and the only way to cure it was, in one way or another, to kill it. There were two rather nutty brothers in Pittsburgh by the name of Bernard and Eddie Fisher, who I worked with for a number of years. One was a surgeon, one was a pathologist. Both were brilliant, lovable, and nuts. And they looked at this data, and there were no trials. There was just the experience of this doctor, and the experience of that doctor, and the experience of another doctor. And they and a fellow by the name of Hagenson said, you know, somehow I don't think that extended surgery is any different than the somewhat less extensive surgery. Well, it's nice to have an idea. But they said, that's based on the model that the tumor goes from here to here to here to here to here, sort of like the horse getting out of the barn. But what happens if, in fact, the tumor starts here and spreads through the body very easily and very early, but they're different control properties of the tumor that determine whether it's going to come back, how it's going to come back, when it's going to come back, where it's going to come back. So a very new notion, oh, you really mean that these cells are under some kind of control? That's a bit crazy. So they did some mouse experiments. And sure enough, in these mouse experiments, they found that very early breast cancers shed cells into the general circulation that could be picked up with the then pretty primitive tests that they had. So they proposed an experiment. And it was a very brave experiment, I dare say, for the patients. It said, If you have a breast cancer less than about 2.5 inches in diameter, 5 centimeters give or take, and with a couple of other criteria, then at random you will be assigned to either removing the breast, they weren't doing the whole sternum splitting thing, but removing the breast in what we call a mastectomy, or just taking out the lump, or just taking out the lump with some radiation added. The prevailing wisdom at the time is you had to do this big operation. So imagine the bravery of the women who allowed themselves to be randomized. And, in fairness, the guts of the surgeons who were prepared to offer that kind of proposal. But it wasn't just a surgical test. This was a test of the fundamental biology of cancer. Does it spread out of control like this? Or is it a total body disease that's subject to some form of regulation? So that was a trial that's called NSABP B06. And when we designed that trial, we needed about 2,600 women to be entered. And actually, Canada and Toronto and Montreal in particular contributed almost half the patients, interestingly enough. Well, when we started to do that trial, we had a heck of a time getting patients to be randomized, because the surgeon said, how can I do this? It flies in the face of everything I believe and everything I've been trained. Slowly we started to get accrual, because some basic data from mice came out suggesting it might be possible, and people sort of looked at the overall efficacy of surgery and how disfiguring it was, and they sort of said, well, okay. And the accrual numbers went up. And we figured it would take about 2.5 years to accrue those 2,500 patients. It ended up taking a bit longer. And the reason it ended up taking a bit longer, we sort of anticipated the trouble at the beginning. But when we got to the end, the accrual rate went way, way down. Why? Because in the absence of any definitive data, the surgical point of view had changed. And how are we going to disfigure women? Of course they should have a lumpectomy. There was no data. We finally completed the trial, and that trial changed literally overnight the management of breast cancer, because it showed that if you did a lumpectomy with some radiation, you had the same effect. So that introduced a kind of notion that it's not simply the bigger the better, the kill the more. And now we swing over to the chemotherapy side of things, where the same notion translated into injecting drugs and giving pills was used. Bigger doses, more powerful doses. And it was based on a piece of mathematics called the log cell kill hypothesis, which said for every doubling of the dose, you kill roughly 10 times the number of cancer cells. And so the logic was, give the biggest dose you possibly could. But some discordant messages started to come out. And one of the interesting messages was from the marrow transplant data. These were people who had acute leukemia, and the marrow was broken. So you replace the marrow by wiping out the marrow and replacing it with a new one. What do we learn from that data? If the notion was you had to kill the last cancer cell, and that killing strategies like drugs or radiation or surgery indirectly were what's going to do it, then the bigger the dose, the better, right? Well, we learned something really very interesting. The patients who survived the longest, who were in effect cured, had a little bit of graft versus host disease. The body started to reject the transplant just a little bit. If they didn't have a bit of rejection, a little bit of graft versus host disease, then the leukemia just roared back. If they had a lot of graft versus host disease, they died of the graft versus host disease, but there was no leukemia to be found afterwards. So it's not just the bigger dose, there's something else going on. And the other thing they saw in the patients who were cured, who had a little bit of graft versus host disease, is that as our testing technologies got better and better, we could look for tiny numbers of cells, and lo and behold, in most of these patients with sensitive tests, we found circulating leukemia cells that had gone to sleep, that had somehow been convinced to behave. So the model was no longer, I got a bad teenager, I'm going to kill him. It's going to be, I got a bad teenager and I've got to discipline him. I've got to teach him kind of the rules. You can see the change starting to happen. It's no longer a killing thing, it's a regulating and control thing. So were there other clues around that might have been the case? Because medicine and science in general don't go in a linear kind of way. They go like this. Bright idea, great enthusiasm, turns out to be not so good, but we learn a little bit. Sometimes we fall backwards, then we go forwards again. That's the way it is. So if you go back to about 1880, when surgical techniques got to be such that you could remove a woman's ovaries safely, there was another nut bar surgeon by the name of Beatson in England who saw occasionally women who had widespread breast cancer, and they were typically postmenopausal. There was nothing you could do. So he got this idea to take out their ovaries. Well, when he took out their ovaries, their cancers melted away for a period of time. That piece of information was sitting there from the 1850s. And now it starts to get pulled forward. As when in my early days as an oncologist treated breast cancer, we used hormones. A postmenopausal woman who had recurrent breast cancer was given estrogen, and guess what? The breast cancer melted away. And then the breast cancer would come back, and we'd stop the estrogen, and the breast cancer would melt away again. So the message, the signal was kind of out there that there were control processes, we just didn't know about them. And breast cancers and lymphomas were the common ones, but in fact it extended to all sorts of cancers. And we had this thing called spontaneous remission. And the notion of a spontaneous remission is that a cancer ups and goes away for reasons we don't understand. And I certainly remember a patient from my Princess Margaret Hospital days who was admitted to the hospital for the umpteenth time for a transfusion. He was dying of widespread melanoma. And we kept transfusing him just so he'd have some energy. And finally, the family sort of said, you know, enough. And a couple of weeks later, he was admitted to the hospital. And someone didn't see that and gave him 3 bottles of blood. And after the second bottle of blood, he said, something has changed. Within 3 weeks, his melanoma was gone. And let me tell you, his blood and the donor's blood were sampled until both became severely anemic. What you knew is there was a mechanism, but you didn't know what that mechanism was. So you always knew that in there somewhere, the breast cancer story, the melanoma story, the odd stories of spontaneous remissions, said there's a mechanism. Now I'm going to jump all the way forward to what's happening now. The whole notion of cancer has changed from how do we kill the last cancer cell to how do we reassert control. We've come to understand that the worst cancer cell is something like 90% normal. Back to the teenager analogy. I think we all understand it. Right? You want to kill him. But it's probably illegal. How do we change that regulatory process? What are the control processes? We talk about the ability to grow, the ability to jump the fence, invade, the ability to metastasize. Those are the three properties that make a cancer. And we suspected then, and have largely proven now, that they're very specific control mechanisms that are genetic. And the disease in the cancer that demonstrated that most clearly was something called chronic myelogenous leukemia. And 20 years ago or so, if you got that disease, and you typically got it in your 50s, then it could keep you going one way or another for 5 or 10 years, but you'd gradually peter out and die. And there was something called the Philadelphia chromosome, which we knew about for a long time. It was a rearrangement. Somehow a bit of chromosome 9 got moved to chromosome 21. Nobody knew why. And nobody knew what it did, but you knew there was something there. So as our genetic technologies improved, we started to understand what that little rearrangement did. And what that little rearrangement in fact did was turn on something called a tyrosine kinase, which caused the cells to divide. So we created a drug for the first time that targeted that tyrosine kinase. Bang! Chronic myelogenous leukemia is now associated with a normal lifespan. And there are a whole sequence of these drugs that are addressing it at a control level, a particular genetic abnormality. So now what's happening in cancer, and I'll come back to other diseases in a minute, is we're not looking anatomically anymore. Not in the same kind of way. What we're saying are, what are the abnormal control pathways? And there are a whole bunch of them that have now been described because we've got the technologies to do it. And if we can find those control pathways, we can target them. And it may well be that in breast cancer, there are a group of target control pathways that are more common, and the ones are the estrogen receptor, the progesterone receptor, and HER2/neu, a growth receptor. And we've been addressing them for a long time. There may be other growth factors in kidney cancers and lung cancers and so on. But if we attack them, we'll be able to reassert control. And again, a dramatic example of that was in a rare form of acute leukemia. Because remember, back in the back of our minds is this notion, we've got to kill that last cancer cell. There's an acute leukemia called M3 leukemia that's really nasty. It's not very common. But what happens is your white count goes way up and you start bleeding all over. And it's because certain white cells don't mature, and the very mechanisms that are used to fight infection are produced in overwhelming amounts. They cause bleeding, and it's really awful. And I remember when I was treating leukemia a long time ago, there was nothing you could do. It was just awful. And a bunch of Chinese guys in Shanghai made an observation that some traditional Chinese medicines that turned out to have a fair bit of vitamin A in them seem to influence this disease. They tried to publish that data and had a terrible time because they're from China. So they got themselves on an airplane and they went to Sloan Kettering and they said, can we try this here? And they gave doses of something called all-trans retinoic acid, directly derived from a Chinese traditional medicine, having no sense, no notion, no belief, no evidence that it killed cancer cells, and yet you were going to give it to these people. But what else were you going to do? They went into remission. And they went into prolonged remissions. And they're still treated to this day with a combination, for the most part, of non-cancer killing drugs. What was going on? These cells, unbeknownst, and I trained as a hematologist, and we knew about B12 and we knew about folate and iron. We knew about those things. Vitamin A for the maturation of a white cell? Impossible. Yet in fact what these leukemia cells had was a vitamin A receptor that was a little broken because of a genetic error. And it couldn't hook on to the vitamin A in the body. So the cells would stop maturing. And the body would say, oh God, I don't have any mature cells. I'd make more, and they'd pile up and pile up and pile up. When you gave the all-trans retinoic acid, you overwhelmed the defect, the cells matured, and the disease went away. And we never killed a cancer cell. So you can see the evidence building that the whole model of treating cancer is very, very different. And that's washed over into any other area of medicine you can think about. Because now we appreciate that the control mechanism not only starts at the gene, but something called the epigene. And I'll come to that in a minute, and then we'll stop for some questions. The gene was identified by Crick and Watson in the early 50s, and we were told that it's a fixed kind of thing. But what we've learned now is, in fact, the gene is a very complicated structure of the DNA, which you've all heard about, being, if you will, the most change-resistant part. And DNA communicates with RNA, and RNA goes to make protein. But as you move out from the DNA, the system is, in fact, somewhat malleable. To make a bad joke of it, you know the story that after many years you tend to look like your spouse? Some people say you look like your dog. All right? Well, there's an element of philosophic truth in it. All right? In the Second World War, the Germans got very annoyed with the Dutch. And they cut off all food supply to the northern part of Holland and induced a substantial famine. And people responded to that by scavenging, as you can well imagine. And then the war ended. And these people started to eat like crazy and gained a lot of weight, and everybody said, of course, they'd been starved. And then someone looked in the next generation and said, gee, the kids, the descendants of these kids from northern part of Holland tend to be heavier than the kids from the southern part of Holland, which wasn't exposed to the famine. It must be mommy and daddy stuffing food in. They remembered all the rest. But then they looked at the third generation, and it's still maintained, and they've identified changed genetic markers for the absorption and the metabolism of nutrients that were learned from the environment. So how does this whole thing come together? Well, the first thing is powerful new technologies. The second is a change from an anatomic sense of medicine to a sense of us as very connected, very subtly regulated organisms in communication with the world as a whole. And we are influenced by that. The illnesses we have are a consequence of those illnesses, of those influences. The cancers we get, the heart disease we get, all of these things are abnormalities not of anatomy, but in fact of control mechanisms. So what does that mean, and how do you look at the newspaper? Well, what it means is that we're suddenly talking about everything as being chronic. All right, we're going to manage cancer like diabetes, right? Going to manage heart disease, less acutely interventive, but more in a regulatory pattern. You're going to see that emerge. And of course, you're already seeing, as people understand the regulatory pathways, you're starting to see the links to the genetics. And what people are now starting to say is, well, back to those Dutch kids, if they've got genes for gaining weight, and gaining weight is bad for your health, and this, that, and the other thing, maybe at age 2 we intervene. That may not be such a good idea. So all these spectacular advances have changed the nature of disease, they've changed the nature of medicine, but they've introduced a few cautionary tales. And the first cautionary tale is that with all sorts of new therapies and new enthusiasms, it takes a while to sort out what's really lasting, what's not just a new enthusiasm that we haven't proved out. And often when we look at these spectacular new treatments, you know, the cure for this, the cure for that, and the Globe and Mail or what have you, everybody rushes off to it, and then when you look at the data down the way, we haven't understood it well enough. We don't understand the long-term consequences. It took us 30 years to understand the consequences of our cancer treatments that were intended to kill. The side effects, the long-term consequences. Got them pretty much under control. We control the nausea and vomiting. We do something about the hair loss. We've cut down on the radiation dose. But we don't yet know the long-term consequences of the control stuff. We don't know the long-term consequences of tinkering with the gene, tempting as it may be. So what happens if we use one of these little gene testing kits that you can get, 21andMe and all that kind of stuff, and it comes up and it says, you know what? You've got a 62% chance 35 years from now of having this bad thing. I don't know, you'll turn out to look like Donald Trump or whatever.
Even in jest.
Okay. Do we intervene? What are the consequences of the intervention? And not only what are the consequences of the intervention, of course, the temptation to intervene is based on the treatments we've got today. And do you really think that the treatments we're going to have in 40 years from now are the same as what we're going to have today? So it's a very, very exciting time in medicine. It's this enormous switch from anatomic medicine to a regulatory medicine. And it's coming up all over. How many people have been reading the stuff about the microbiome? You know, all the stuff the nutritionists have been telling us, take probiotics, this, that, and the other thing. And what's the relationship between the bugs in your gut and the rest of you? Well, I can tell you when I was treating acute leukemia, Way back when, the notion was you wiped out all the bugs in the gut because those seemed to be what caused the infections that made it so bad for leukemia patients. Some people were sort of said that doesn't make a hell of a lot of sense because they just tended to die of other bugs. Now we're starting to understand that microbiome is part of the same regulatory control process. So I want to leave you just with the cautionary tale before I stop and learn from you by your questions, to say it's an extremely exciting time. But our entire concept of illness, our entire concept of biology has shifted in a way different than anything in the last 250 years, and we're just figuring it out. And the ramifications of that extend not only to individual care or what we see in the test tube, but how you devise a healthcare system. If in fact people are going to be monitored for risks of disease and early precursors of disease and whatever, are they going to have to be tied to Sunnybrook Hospital around the corner? Or do we have to have a healthcare system that can deliver anywhere in the world? So it's a huge change. It's an exciting change. But it's one that leaves all of us a little uneasy simply because the paths don't seem so clear as they were before. When I started as an oncologist treating breast cancer, we did this or this or this. Clear as a bell. We knew it all. The cardiologist put you to bed for 6 weeks. Clear as a bell. We're not so clear now. And the humility that has to come with that probably is the greatest virtue of the whole thing. So I'm going to stop there. I'm going to ask if there are any questions.
One of the things that you said is that the largest number of deaths are due to cancer, and that will increase.
Yeah, this gentleman said, one of the things I said was the largest cause of death was due to cancer, and that's going to increase. That was actually Rob who said that. Cardiovascular disease, stroke, cardiovascular disease is still the largest. Cancers do increase because they're age-related. The increase in cancer is also somewhat an artifact of increased detection, which is another conversation for another talk. We've got these very sensitive technologies that pick up very early cancers, and people are now, given this whole rethinking about how the body works, saying, well, is a very tiny early cancer just a smaller version of a late one? And the evidence seems to suggest not. So it's going to shift, but for the moment.
I wasn't talking about the incidence of cancer, I was talking about deaths.
Well, the deaths are still cardiovascular diseases and stroke. Still outmatch cancer, except in certain areas where cancers are highly prevalent. For example, in southeastern China, where liver cancer, for a whole bunch of reasons, is the leading cause of death. But it's still cardiovascular diseases, which is one of the reasons this program is so important. Plug.
What about stem cell technology, and how does it relate? When is it able to be used for all diseases?
So there are a number of different aspects of stem cell technology. To be unfair to it for a moment, occasionally people who lecture about stem cell technology go back to the Middle Ages and talk about popes and other people being transfused with young lamb's blood to restore young cells. That went on in the Middle Ages. So in a sense, that's a philosophic precursor, but it's also an aside. A stem cell is a cell that hasn't become specialized. It's like a physician who's not become an oncologist. Okay? Knows a lot more about other things, everything from snake bites to broken legs to a little bit of cancer to a little bit of whatever. But he hasn't become very specialized. So if in need, a good GP can pick up surgical skills, for example, a lot better than I can. The stem cell is the same kind of idea. What you do at one level with a stem cell is to use its powers to regenerate, to create missing cells. You wipe out the cells you don't want, and you give some of these stem cells that repopulate, and that's the marrow transplant story for acute leukemia. The other thing you do with stem cells is you can replace a defect. So for example, people who have sickle cell anemia, some of you may have heard of it, it's more common in Caribbean and African countries, and in fact sickle cell anemia evolved as a means of protecting the population from malaria. It was a genetic response over thousands of years. And if you got one sickle cell gene, this was a good idea, but if you got two, which is a real possibility, that was a bad idea. So what you do with the stem cell is you inject normal hemoglobin stem cells and you add them to the population, and hopefully they will replace, if you will, the defective sickle cells. Taking it a step further to the genetic modification, they've now identified a particular gene defect that they can manipulate in the context of, if you will, an immune infusion, and it seems, on some of the data that's come out in recent weeks, you can actually eliminate hemophilia. So again, it's the control thing. Do you use the cell to do it, or do you use another mechanism to address the metabolic defect? So we're thinking much less like architects, if you will, or block builders, and much more like engineers and control therapists and control theorists. What's the control mechanism? How much? Too much is too much. How much is too much? That's what the struggle is now. And what are the measures of control? When we measured tumors before, we'd say, well, 3 centimeters is bigger than 2 centimeters. But maybe the question is that control mechanism is turned on a little too much rather than too little, and the size doesn't matter. Watch over the next 5 or 10 years. It's really going to be a transformation. Yeah.
My sister got breast cancer in her early 20s, and she had one of the radical mastectomies that you were talking about, with everything removed, including the muscle. So she had the back muscle brought forward to reconstruct. But since then, she's tested positive for the BRCA1.
BRCA1.
Yeah. And then, so she's had her ovaries out and the cancer's come back, and so she's having another mastectomy on the other one. But it seems like the same thing, like, so.
What motivates every physician, every good physician, is the realization we haven't solved it yet. When our patients come back in difficulty, despite what we know, despite the progress we've made, we're reminded we're not there yet. BRCA1 and BRCA2 were the first genes really tagged to a solid tumor, other than some pediatric ones, which were quite uncommon. And interestingly enough, they're not genes that are part of the cancer. They're genes that are part of the normal body repair toolbox that are defective. So put it in an analogous way, you have a gene that's not operating properly, you have an electric fixture that's not operating properly, you bring out your toolbox. You got hammers, saws, screwdrivers, all those kind of things. BRCA1 and BRCA2 are 2 different toolboxes, and it's not one gene, but each of the areas on a chromosome represents a collection of repair tools. Screwdrivers, hammers, those kind of things. And one of the hammers is defective, or a screwdriver is missing. And some of those defects are common and easily picked up and highly predictive of trouble. And so you do all this stuff. Others, you say, gee, that screwdriver doesn't quite look right, but despite having a large population base, we don't see a measurable increase in breast cancer with it. But it's another really, really good example of how here we're using the gene to detect, later on we're using the gene to treat. I'm sorry she's having that trouble,
Yeah.
but we've got more and more things, but we're not there yet.
Well, she's been asked to take part in a study as well, like for blood tests to try and determine if there's a cell that they can pick out.
Correct.
That would, yeah.
And not to raise false hopes, to give you a sense, there were quite a news blast a few weeks ago in an article in Nature about 3 women in Colorado who had breast cancer that was out of control and resistant to treatment with anything that was going. And these were women who were at death's door. And some research physicians said, look, we think there's some control genes here with some investigational drugs we think we can rejig. Would you volunteer? And they did. For 2 of the patients, didn't make much difference. Within 6 weeks, the 3rd patient had her tumor disappear, and it's been gone for 3 years, and she's back skiing. It's like the melanoma story I told you before, but suddenly we've got handles on this. And the common cancer area where this is now changed everybody's thinking is lung cancer, where I can tell you the chemotherapies we used to give didn't help much. But now they've got targeted therapy, some of them developed in Toronto. One of my close colleagues, Fran Shepard, is getting one of the Gairdner Awards for her work in that. And the Gairdner's is a reasonable predictor of the Nobel Prize. But it's not killing the lung cancer cells, it's getting them to damn well behave. Yeah.
There's an interesting tension between the innovators that you're talking about and the mainstream practitioners.
Yep.
And I just wondered what you thought were the best ways to encourage the innovation to take place and for the change to also take place, especially given the presence of such a large profit incentive within and behind the whole medical field.
You want the one-line answer. It's a huge challenge because on one side you want that innovation to go ahead. You would like 1,000 women to get the medications that I just mentioned. At the moment, we don't have, in the regulatory setting, a robust, researched, documented set of predictors so that you can balance the benefit against the risk. In breast cancer, we've got estrogen receptor, progesterone receptor, HER2, and a couple of others, and those allow us to say we can give these drugs knowing we're very likely to get a lot of bang for relatively little toxicity. We don't have a robust structure for many of the others. And so pushing it quickly, which is what you want to do, has to be tempered about the oldest maxim in medicine of all, and that's do no harm. So that's a very, very powerful tension. Then there's the one about the profit motive. And you see that every day. And in my discussions with government, working with, teaching the law school about innovation law in health, we have to figure it out. And you know what? The rules, the laws, the culture tend to fall behind the science. They're kind of playing catch up. So I sure as heck don't have an answer. You want the innovator to have a profit of some sort. But how much profit? And in what terms? And, you know, if they're making a huge amount of money and your insurance company is paying for it, But on the other hand, can't keep doing that. It's unsustainable. So that's going to be argued out and fought out and learned from and mistakes garnered from for a long time. I don't have an answer. But you've got the problem well articulated.
And I think that's probably an excellent point to stop. Dr. Schipper, thank you very much.